Hi guys, it's Professor Costa and we're back with Advanced Central Perfusion, Part 2. Okay, so now we're talking about valvular heart disease. So that just prevents efficient blood flow, right? So we have little gates within our heart, we call them valves. They're a gate, right? And as it prevents blood flow from going back and forth. When we squeeze either the atria or the ventricle, we want the blood to go in one direction only. We don't want it swishing and swashing back and forth. So one-way gate, right? That's how this is supposed to work. And this can be acquired or congenital. Some people are born with yucky valves, and some people, through no fault of their own, develop diseased valves. And then there's some people that do some risky things that end up with valve disease. So we can have stenosis, which is the tissue just gets thick and narrows, right? We get some scar tissue. Insufficiency, which is also called regurgitation. So insufficiency and regurgitation are the same thing. The valve is incompetent, so it prevents complete valve closure, right? So we have a leaky gate, right? We have blood that's squirting back in the wrong direction, and we don't like that. And then we have prolapse, which just means that the valve leaflets protrude into the left atrium. That's the mitral valve prolapse during systole, right? So the gate doors kind of go backwards a little bit. None of these are good things, right? We don't want the one-way valve or the one-way gate broken, right? Because our heart works to move blood in one direction through the heart, through the atria, into the ventricle, into the lungs, back into the heart, and out to the body. And we want it to do it efficiently. We don't want extra work involved. We want everything to be oxygenated well. Okay. So a review on the right side and the left side. Just like my prior lecture, though, I want you to think big picture. So if your valve is on the right side and it's failing, then chances are you're going to have signs of right-sided heart failure. And if the valve is on the left side, your chances are you're going to have signs of left-sided heart failure in general. All right. So on the right side, we have our tricuspid valve. And usually we worry about stenosis and insufficiency. So stenosis is that stiff, thickened, scarry type tissue that doesn't open very well, and then it doesn't close very well. So it's, rusty old gate. So you have to kind of kick it to get it to open, and then once you do get it to close, it doesn't close tight. So it's leaky, and then it's just hard to move in general. And then just insufficiency, where it's leaking, it's not closing with each beat, and you've got some back and forth blood flow, which we don't want. Then we can have pulmonary stenosis or insufficiency, same things. On the left, we can have mitral, which is that pulmonary hypertension stiffens the lungs, so it can cause pulmonary hypertension. And we can have insufficiency during diastole, and we can also have prolapse, where the leaflets actually protrude back during systole. We can have aortic stenosis, which this one's the worst one. Right? So think about what the aorta is supposed to do, right? The aortic valve is supposed to, that's the gate into the rest of the body. And now we have an aortic valve that doesn't open well, so the left ventricle has to kick it to get it to open, and then it doesn't close very well. So it's just leaky back and forth and causes extra work for our heart, right? So this is the most life-threatening one. Not saying the rest are great, and I wouldn't be all excited about them, but this is the one with the highest mortality rate. And then the insufficiency. We can also have insufficiency, and that can occur during diastole. So a valve review. So we look on the right side, and we have our tricuspid valve, named tricuspid because it's got 3 leaves, right? And then we have our pulmonary valve, right? Then we have our mitral valve. And then if you can look, you can see the aortic valve exiting. That's our exit into the main vasculature. So it's leaving the left ventricle into the aorta and into the rest of the body, right? So that's the scary one. We don't want the exit blocked, right? We want the exit open and available for business. And we don't want leaking back. Once you're out the exit, you don't want to have to go back into the heart. So valvular heart disease. So we're going to do a full assessment, right? Personal and family history. Have they ever had rheumatic fever? So that's where we can have a bacterial infection that actually can cause damage to the valves. Recent infections, invasive procedures, and are they easily fatigued, right? Because anyone that has heart failure, regardless of the cause, is going to have fatigue, okay? Nursing priorities, we want to maintain cardiac output, right? We have something that's causing heart failure. We want to prevent complications like infection, dysrhythmias, or heart failure. We want to control the symptoms. So sometimes these patients will have chest pain, shortness of breath, etc., because they have heart failure caused by a valve issue. All right. And patient teaching. A lot of patients with valvular heart disease end up on things like antiarrhythmics, or they end up on clot medications. So they may be on a daily aspirin, or they may be on warfarin, or they may be on one of the newer medications. Okay. Nursing diagnoses. So we're not testing on nursing diagnoses anymore, but knowledge deficit related to valve surgery could be there. Altered tissue perfusion, alterations in cardiac output, you name it, right? Activity intolerance, so forth. Okay, so we have something that's causing heart failure. We want to keep it from getting worse. We want to minimize risk complications. Remember, if you have turbulent blood flow, anytime we have turbulent blood flow, we're at risk for a clot, right? Patient education especially, right? How to maximize your ability to move around and have a productive life, or, tolerate even your, ADLs. Or are we teaching you about new medications? We can have surgical interventions. So we can actually go in and either, fix the valve itself, or we can replace the valve. So we have ways to fix this if it's severe enough. So we have some repair procedures. They can do a valvuloplasty, which they literally just kind of, if the leaflets of the actual gate, the valve itself are broken, sometimes we can fix those surgically. We can do an annuloplasty, which tightens and sutures malfunctioning valve rings, makes it tight. And we can do a valvotomy. So that if we have such bad stenosis that the gate barely opens, then we may have to dilate that and help it open up a little bit because of the scar tissue. Okay, so valvular heart disease. So we may treat this with an actual replacement. So if the valve is just not doing its job at all, we may take it out completely and replace it with something else. So there's two main types. This would be a really, really good slide to memorize, okay? Because I like to test on it, but it also shows up on your HESIs, and more importantly, for some of you, will show up on your NCLEX exam. So this is a good one to know. So first one is called a mechanical prosthetic valve. So this is something we made in a lab, like we made it. Somebody works in a factory and they make this valve. It has some metal components. It is durable, but remember, it's a little machine that we make and we're not infallible. Thromboembolism is a huge problem with these. And so the patient is on anticoagulation therapy and patient testing for life. And the reason why is they prefer to use VKA, which is vitamin K antagonist, medication, i.e. warfarin or Coumadin. And so we're looking for a therapeutic INR around a 3, so the ballpark around a 3, so 2.5 to 3.5. And that number may change slightly depending on whatever source you're looking at. So remember, if they have something that we made in the lab and we put into you, then you're going to need to be on medications for life. So a VKA like warfarin, or also an antiplatelet. A lot of these patients are on warfarin and maybe even a baby aspirin. Though I'll tell you, in reality, I have had patients just because they're stubborn and they absolutely refuse to take the warfarin, and they may choose for larger dose aspirin. But ideally, they're going to be on Coumadin therapy. And remember all the teaching that goes along with Coumadin. Huge knowledge deficit, all the dietary stuff, watching for bleeding, so forth. So that's a huge component of our job as nurses, is that we have to teach our patients how to take care of themselves when they're on that med. Or we could do a bioprosthetic valve. So that wasn't made in a lab. That was something we took out of another animal or another human. It is less durable and it can scar or calcify, but it doesn't require the long anticoagulation. So usually just a couple of months post-op. So, you know, risk-benefit ratio. It may not last as long, but you also don't have to be on Coumadin for the rest of your life. That is a choice up to the surgeon and the patient, right? Okay, so right-sided valve disease, the tricuspid valve. So the first one we could have is tricuspid stenosis. And remember, stenosis, that's that really stiff valve that doesn't want to open and then doesn't shut well. So this is, you know, the worst of the two. Easily fatigued. We're going to have signs of heart failure. They're going to have sometimes fluttering sensations in their neck, and that's from that backflow. Remember, the valve doesn't want to open, and so we can have backflow. And it can also leak, right? Cyanosis, so we're not oxygenating that blood. It's not going into the lungs, and we're going to have a cyanotic patient. Or right-sided heart failure. That's basically what we're going to be experiencing here. Treatment may be a low sodium diet, so we want to decrease that preload by reducing sodium consumption. This rarely occurs by itself. It's usually another valve or another part of the heart is affected. And this may also be treated with surgery, where we actually do surgery on the leaflets, or we could just replace the whole valve altogether. The next one we could have is the tricuspid insufficiency. And this is just a gate that doesn't shut all the way. It's leaky. We have backflow back and forth. Not as severe, okay? But we're also going to have signs of right-sided heart failure. We could have anorexia, nausea and vomiting, seesaw chest movements during respirations. This one, if it's chronic and if it's associated with infective endocarditis, then we would replace the valve, right? So we may do medical prescriptions, like we may give you medications. But remember that stenosis is usually worse than insufficiency, though none of this is great. We want a tricuspid valve that only opens when it's supposed to and closes up tight when it's supposed to. And if we don't have that, then we're going to have signs of right-sided heart failure. All right, guys, so we're still looking at the right side, and we're looking at the pulmonary valve. So the two main types that we're dealing with is pulmonary stenosis. Remember, that's that stiff gate that doesn't open and then doesn't shut well. And we're going to have signs of right-sided heart failure. We're going to have dyspnea, fatigue. We may even have some syncope. This usually requires no treatment, though if we have ventricular failure, we may have to do surgery, okay? Pulmonary insufficiency is usually asymptomatic, again, unless right-sided heart failure develops, and then we can also do surgery, and it does depend on what caused it in the first place. All right, left-sided valve disease, mitral valve. This is the big kahuna, right? The mitral stenosis. So we have a mitral valve that doesn't open. The body has to work hard to make it work in the first place, and then it doesn't close. So we're going to have some pulmonary congestion here, decreased cardiac output. We could also end up with right ventricular failure, dyspnea, hemoptysis, orthopnea, and angina. If it doesn't impact the patient, we're not going to fix it. So if they're asymptomatic, then there is no therapy. A lot of times these patients go into AFib. So we have to, if the patient has AFib, they may be worked up to see if they have mitral stenosis. And obviously heart failure, because we're dealing with a heart valve. DIG, diuretics, a low sodium diet. We may do surgery on the valve to enlarge it, because remember, this is stenosis, so it doesn't open well. So we may want to make sure that we dilate that and it's able to open it back up. Mitral insufficiency is just the leaky mitral valve. We may have some pulmonary hypertension, right-sided heart failure, dyspnea, fatigue, dizziness, and syncope. Okay. Medical treatment as mitral stenosis is the same, but we may do an annuloplasty, which is that tightening the ring around the valve to help it close up better, or we may put in a new valve. Okay, so left-sided heart disease, we may have mitral valve prolapse. So that's where the actual leaflets fall, like billow out, I guess that's what it would be called, a floppy mitral valve, Barlow syndrome, billowing mitral valve, and it's quite common. So this is, we're going to have that left-sided heart disease. We're going to have, as it gets worse, we're going to have more fatigue, chest pain, palpitations, and even syncope, where we're not getting enough blood to the brain. So we're going to be treating that with beta blockers for tachycardia. Remember, when the heart isn't putting out as much, then when our cardiac output drops, our heart panics and starts to beat faster. And we're going to give beta blockers to avoid that. And we're going to have some conduction issues too, and that will help reduce our PVCs. And we can also end up replacing the valve. So mitral valve prolapse, you'll see that bulging in B. You'll see that little bump. That's that billowing. It's supposed to stay relatively flat when it closes. If you look in figure A, you'll see that the two sides of the gate shut and stay shut. In mitral valve prolapse, there's a little bulging or billowing of the valve, and that impedes the amount of what's allowed, to pump out. And we can also get some regurgitation with that as it leaks, okay? So the blood pushes on the valve instead of being pushed out, and we can also have leaking. Our aortic valve, okay. So aortic stenosis is really scary, okay? So this is the outlet. All the blood going to the rest of the body is now blocked or partially blocked, because we have a gate that won't open and we have some leaking. So we can have angina, syncope, definitely have left-sided heart failure, and then they can back up into the right, and we can also have right-sided heart failure. All right, if they're not symptomatic, we're not going to treat them. But if they're symptomatic, if they don't get treated, usually death is within 3 years. It's very serious. All right, because that heart has to, especially the left ventricle, has to push and push and push and push against the resistance of that, crappy, scarred, stiff gate. And after a while, you're going to end up with some hypertrophy in that left ventricle, and we know what happens with that. All right, aortic insufficiency, we have a leaky aorta. We can have, again, dyspnea on exertion, left-sided heart failure, and then it can back up into the right? Okay. The heart can beat with unusual force, and we want to reduce preload, and we want to manage the signs of heart failure with DIG and diuretics, okay? Or we can surgically replace the valve. All right, so here's our picture. We have the aortic valve, and normally it's open. It's got a nice wide open, and when it closes up tight. And you can see with the stenosis, again, our gate won't open, so we don't have a nice open gate, and the body is working harder and harder just to get the blood through that narrow opening. And then it closes and it's leaky. So we have backflow, so it's not an efficient system. And remember, this is the blood supply for the entire body we're talking about. Closer view. See the stenotic valve? It's all scarred tissue and gross and like not clean, and it's open and it's stiff, and it won't open well and it won't close well. Regurg, again, is just leaking. It's insufficiency. So for our aortic valve, we want that door to shut so that the blood that we just pumped out of the heart doesn't flow back in. An abnormal aortic valve fails to close, and it allows blood to leak backwards, and that's going to cause a backflow in the rest of the system. It's also going to prevent that oxygenated blood from moving forward.